hospital. So the informant was mother who was 24 years from Eluru. And coming to the newborn information, baby of Hasina who was 48 hours of life. Date of birth was 18th April 2026. She was delivered at 7:20 p.m. late preterm, 36 plus 4 weeks of gestation. Female child with birth weight of 2,600 grams. Uh, Appropriate for gestational age, cried immediately after birth, born to a 24 years gravida mother, P2L2, through normal vaginal delivery at NRIGH. So the presenting complaints were mother noted yellowish discoloration of eyes at 48 hours of life. She noticed first at face, then that progressed to hands and legs. So was a history of inadequate perception of milk production in the mother, and also there was decreased frequency of baby feeding. There were no history of yellowish discoloration of urine or clay colored stools or decreased frequency of urination in the baby or hypothyroidism in the mother, delayed passage of meconium or lethargy or seizures, high pitched cry, poor feeding, fever, or any birth trauma or purulent discharge from umbilical cord or ear discharge. So the antenatal history was at 24 years gravida with 36 plus 4 weeks of gestation, who is a housemaker, conceived spontaneously at the age of 24 years within 1 year of the previous pregnancy, diagnosed by urine pregnancy test at second month at home, confirmed by USG scan at the fourth month. Her LMP was 30th July 2025 and expected delivery date of delivery was 6th May 2026. Her antenatal visits were 8 out of 10 and the mother's blood group is A positive. Age at marriage was 20 years. Marital life was 4 years. Age at conception of this second pregnancy was at 24 years. There were no history of any consanguinity in family or usage of any drugs by the mother or any medication uses or any maternal malnutrition. So the menstrual history was she attained menarche at 13 years of age with regular cycles. Cycles were 3 to 4 days in frequency, about 28 to 30 days of cycles. The flow was moderate, there were no clots and no dysmenorrhea. Her obstetric history is G1, gravida 1, conceived spontaneously within 1 year of the marriage. That was full term, male child, birth weight was 3 kgs. There were through normal vaginal delivery, cried immediately after birth, and there were no NSU admissions. Coming to gravida 2, she conceived spontaneously within 1 year of previous pregnancy. That was diagnosed by urine pregnancy test at second month, confirmed by USG scan at fourth month. So the trimester 1, there were no history of any excessive vomitings. Folic acid supplementation was taken. Dating scan and nuchal translucency scan were done. There were no histories of fever with rash or radiation exposure or drug usage or urinary tract infections or vaginal bleeding. It was uneventful. Coming to trimester 2, she was on regular antenatal checkups. She used iron, folic acid, and calcium supplementation. 2 doses of TT vaccine were taken at fourth month and fifth month. Quickening felt at the fifth month. Oral glucose tolerance test was done. Thyroid ESH was done. TIFA scan done, and mother was informed that everything was normal in the scan. There were no history of any blood transfusions or abdominal pain or fever. So coming to trimester 3, iron, folic acid, and calcium supplementation were continued. Growth scan was done, which showed AFI was 25 centimeters and estimated fetal weight was 2.7 kgs. OGTT TSH done and normal. No complaint of pedal edema or fevers or blood transfusions or bleeding per vagina or leaking per vagina or decreased fetal movements or prolonged labor or severe anemia or burning maturation. So the natal history was female baby delivered through normal vaginal delivery at NRIGH with vertex presentation conducted by doctors and trained nursing staff. History of history of 2 times of clean vaginal examinations were done in labor. Baby with birth weight of 2.600 kgs, appropriate for gestational age, and cried immediately after birth within 1 minute of life. Baby with Apgar score of 6 by 10 at first minute was noted and 9 by 10 at the fifth minute. There were no history of any analgesics or anesthetics given to the mother. So coming to the postnatal history, the baby was 36 plus 4 weeks of gestation, who was a late preterm female child, passed meconium within 4 hours of life and passed urine within 24 hours of life. Feeding was initiated within 1 hour of life. Umbilical cord was intact at 35 hours of life. There were no history of vomitings or convulsions or bell activity of the baby. Baby passed pulse oximetry screening in all the 4 limbs. TSH screening was done and was 11.85 micro international units per ml. Immunization were done and otoacoustic emission was done and normal. She passed meconium at 4 hours of life, urine at 6 hours of life. There was no history of any neonatal seizures or pre-lacteal feeds. So coming to the feeding history, baby was given express breast milk within 1 hour of life. Feeding was done every second hourly. Nighttime feeding was done on the demand. There were no feeding difficulties or latching difficulties noted by the way. So immunization history, birth vaccines were taken with BCG, hepatitis B and OPV. So coming to the family history, the age of the father was 28 years and mother is 24 years. There were no history of any consanguineous marriages in the family or significant familial diseases or familial congenital diseases or sudden explained deaths or jaundice in the baby or jaundice in the sibling or any splenectomy or abdominal surgeries in the family or any gallbladder diseases or there were no blood transfusions in the family. So this is a pedigree chart. You can see the first one was a male child and second one is a female child. It indicated by the red arrow. So coming to the socio-economic history, father studied BSc computers. He is an electrician by occupation, currently not working. Mother studied till 10th class. She is homemaker. They belong to upper lower class according to the modified Kupus form scale. It was given points. The total points were 10. Uh, Based on the education, he was graduate 6 points. Occupation was unemployed 1 point, and per capita income of the whole family was 8K. So the total points were 10. They belong to upper lower class. So the summary: 48 hours of life, old girl baby, born to non-consanguineous couple through normal vaginal delivery, cried immediately after birth, adequately immunized, started on direct breastfeeds, presented with yellowish discoloration of sclera, hands and legs, with history of inadequate perception of milk production in mother and decreased frequency of baby feeding, is admitted in NICU in view of neonatal jaundice. So coming to the general.
Sarath, can we just stop here? We will first discuss the history part and then we'll get back to the examination.
Okay.
Okay. Now just go back to the first slide. Right. Yeah. Here you have just informed that the baby was brought to NICU. Then the next. Coming to the presenting complaint, the chief complaint is yellowish discoloration on point. Then moving on to the cause of it. It is history of perception of inadequate milk production in mother.
Yes.
Okay. The mother usually not just many mothers have the perception of not enough milk. Right. And there is decreased frequency of baby feeding. Fine. You have asked for discoloration of urine and stools. Why?
Ma'am, in coming to urine discoloration, if there are any obstructions in the intestine, that is, if bile doesn't go to the intestine, that means conjugated bilirubin is there, and that gives yellowish discoloration. And coming to clay-colored stools in conjugated hyperbilirubinemia, if there is not enough stercobilin, so the stools are not yellowish in color, so they look like clay color.
Okay. Okay. I wanted to ask you, why did you inquire about hypothyroidism in mother?
Ma'am, hypothyroidism in mother because of the low thyroid hormone that leads to decreased UDP GT that is UDP glucuronide transferase, which is essential for the conjugation of bilirubin.
Okay.
So if the mother is hypothyroid, that UDP-GT is not adequately produced and there is no conjugation.
Yes. And if the mother is thyroid, non-hypothyroid, the baby is also at risk for hypothyroidism and it can lead to prolonged jaundice.
Yes.
Okay. What are the normal risk factors for jaundice in a baby, in a newborn baby?
I'm first coming to if there is inadequate feeding.
Yes.
And also due to breast milk also in some conditions due to breast milk, there are some metabolites of progesterone. Due to that also there will be decreased conjugation. And also due to beta glucuronidase, there will be increased enterohepatic circulation.
Okay.
That will be the risk factor. And also if there are any some conditions like incompatibility of the blood RH, IBO.
Yes.
And also due to familial diseases like hereditary spherocytosis, G6PD deficiencies.
In your
And
case?
that is due to decreased feeding by the
Other
baby.
than decreased feeding, what is the risk factor in your case? It is prematurity.
Yeah, premature.
Okay.
Yes.
And you should always rule out sepsis first.
Yes, ma'am.
Yes.
Okay.
And why did you ask for lethargy, seizures, high-pitched cry?
These are caused by sepsis, ma'am, and also if there is high bilirubin, that leads to kernicterus, and these are the early clinical features of kernicterus.
Yes, acute bilirubin encephalopathy.
Encephalopathy.
Yeah, okay. Did you miss anything? Do you want anyone? If you can answer. Anything relevant negative history you would like to ask? Fine. Let us go back. Next slide. Okay. So this is all fine. Here, very good. You mentioned mother's blood group. Next. Yes. What drugs cause jaundice?
Some drugs like sulfonamides, nitrofurantoin, antimalarials.
More?
Acetaminophen, salicylates, aspirin.
Okay. Any drug that is used in labor during the delivery process that causes jaundice? Name one drug that is used during delivery that causes jaundice, and name one drug that is given to the baby and can cause jaundice. Okay, one given to the mother during delivery is oxytocin. Okay, and given to the baby is just in case higher doses of vitamin
K.
Yeah. Okay. Next. This is fine. This is all good to go. Next. Yes. Why would you like to ask about fever with rash here in the first trimester?
Ma'am, any torch infections in our mothers during antenatal.
Yes. Okay. Next slide. Next. Yes. Anything here that can help you out with your differentials?
Severe anemia
Yes, very good. Severe anemia, blood transfusions,
Blood transfusion.
right? Okay, next.
Blood nutrition.
This is all fine. Next. Yes. Here you have mentioned feeding is initiated within 1 hour of life. And the urine was passed within 24 hours and meconium was passed at 4 hours. What is the normal age limit you can wait up to for the baby to pass urine and meconium?
According to latest guidelines, we can wait up to 48 hours of life for both meconium and urine to get passed.
Okay. One common cause, I have asked you one question back in the negative history. If you missed anything, it is delayed passage of meconium or constipation. What you should rule out?
Delayed passage of meconium causes bilirubin to stay longer in the intestine.
Yeah, I mean, what condition you should rule out or what you should suspect?
Biliary atresia.
No, it's not related to jaundice. What underlying condition I mean to say? Constipation, delayed passage of meconium. You can tell me two things. Yeah, I can find people answering.
We can look for patent of the anus. The anus is patent.
Okay.
And also we should look out for the feeding difficulties of the baby.
Okay. Now the answer is hypothyroid. You should suspect hypothyroidism and Hirschsprung's disease. Okay.
Okay.
I just wanted that from you. And how long, when does the cord fall off usually? In a normal newborn?
After 5 days.
Okay. It is usually 1 week. It can happen sometimes before that. Okay, next. Yes. You have, what is the normal TSH of the baby? You have done TSH here. It is 11.85, but what is the normal TSH? Okay, it is less than 10. Okay, fine. Next. Okay, so the mother in your case is giving nighttime feeding, and yet she feels baby is not feeding well, and the baby is also feeding almost every second hourly. That's fine. Birth vaccines taken. Okay, next. Is the baby on exclusive breastfeeds, or there were any formula top-up feeds were given?
No, ma'am, exclusive breastfeeds.
Okay, next. Okay, here, what do you want? At risk, in at-risk babies, you should always give a 3-generation pedigree chart. Okay. But here there is no history of anything in the family. Okay. Now tell me, why did you inquire about sudden explained deaths?
I asked because if there are any metabolic diseases in the family like galactosemia, tyrosinemia,
Okay.
which are differential diagnosis for hyperbilirubinemia.
Very good. Now give one condition because you have asked about familial diseases. At least one. I think you can mention about 2 to 3. Familial diseases that run in the families.
Hereditary spinocerebellar
Yes.
G6PD deficiencies.
No.
Alpha-1 antitrypsin deficiency.
Genetic disorders.
Down syndrome.
Genetic. Okay. That doesn't run in the family. Okay, it is progressive familial intrahepatic cholestasis. Okay. Why did you inquire about jaundice in sibling?
There will be chances for the next baby to get.
You will get a clue about any incompatibilities. What is the common incompatibility we come across?
RH negative.
No, the common one is ABO incompatibility. Okay, followed by RH. Right? There are minor blood group incompatibilities also. Can you mention a few minor blood groups?
A, B, B.
Minor blood groups. Yeah, in ABO incompatibility, actually see, RH incompatibility is more severe disease compared to ABO. Okay. In ABO, OA setting is more severe than the OB setting. I mean to say, mother is O positive, and if the baby is A positive, it can lead to a more severe disease, but not compared to RH incompatibility. Okay, and I wanted you to mention some, at least one minor blood group incompatibility you know, or minor blood group you know. Okay, minor blood groups include Kell, Lewis, Duffy.
Duffy.
Yeah, Duffy, very good. Cool. Then next.
Next slide.
Yeah, next. Okay, fine. Good to go. Let's go with examination.
Coming to the general and
Your
physical
summary
exam.
is precise and is on point. Very good on that. Next.
So coming to the general and physical examination, baby is alert, normothermic 36.5 degrees Celsius, spontaneous eye opening is present, posture is well flexed and having normal tone. The color of the baby was icterus up to hands and legs. Activity moving all four limbs spontaneously and response to the stimuli was noted. There were no visible congenital anomalies noted. So coming to the vitals, temperature.
Last slide. Sorry, yeah. Okay. Can you give me the states of consciousness in a newborn?
1 point is given if the baby is alert.
Mhm.
Arousable. Next one is arousable but sleeping.
Okay. No, 1 is deep sleep with regular respiration. Okay. 2 is active sleep with irregular respiration. And then 3 is drowsy. 4 is quiet and alert. 5 is active and alert. 6 is crying. You want me to repeat it? 1 is if the baby is in deep sleep with regular respiration. 2 is active sleep with irregular respiration.
3 is
3
drowsy.
drowsy. 4 is quiet and alert.
Alert.
5 is active and alert. 6 is crying.
5.
Okay. So, how is the posture in a preterm baby?
Universal flexion position.
In a preterm baby, normal term baby is well flexed. Preterm baby is slightly semi-flexed. Okay, there is certain amount of hypotonia. In your baby, it might not be there because the baby is 36 plus 4, almost term, right?
Yes, ma'am.
Yeah, fine. Okay. So your baby is having icterus up to hands and legs. Now, come on, let us talk about Kramer scale. What is Kramer scale?
Kramer scale just signifies the dermal discoloration, dermal yellowish discoloration. There are 5 points given.
Okay.
Coming
Zone
to
1 includes, and how much bilirubin?
Ma'am, coming to the one, it includes up to face and neck. It will be 5 to 7 mg per day. And upper trunk, chest and upper trunk, it is given 7 to 9. Lower trunk and legs up to knees, it is given 9 to 11. And legs up to knees and forearms, it is given 11 to 15. And palms and ankles, palms and soles are given more than 15.
Okay, fine. Next.
Next slide. So the vitals, temperature is 36.5 degrees Celsius, heart rate was 145 BPM, respiratory rate 60 cycles per minute, BP is 75 by 40 mmHg, saturations were 98% on room. Coming to the anthropometry, the weight of the baby at birth weight was 2,600 grams, comes under 10 to 50th percentile. Length is 49 centimeters, 50 to 90th percentile. And head circumference is 33 centimeters. It comes to 50 to 90th percentile. The today weight, that is on 20th April, was 2.470 kgs. 5% weight loss was noted.
Okay. Classify neonates based on weight.
Low birth weight, less than 2.5 kgs.
Okay.
If it is more than 2.5 kgs, it is a macrosomic baby.
No. Come again.
Less than 2.5 kgs is low birth weight.
Okay. There is low birth weight, very
Very
low
low
birth,
birth.
and extremely low birth weight.
Less than 2 kgs is very low birth weight. Less than 1800.
Mm.
More than 3.5 is
What is average Indian baby weight?
2.6 kgs.
Okay. 2.8 kgs is average Indian baby weight. Normal should be more than 2.5. Low birth weight, less than
0.8.
2.5 to, 1.5 to 2.5 is low birth weight.
Okay.
Okay. 1 to 1.5 is very low birth weight. Less than 1 is extremely low birth weight.
Okay.
Got it? Okay. Now, what is AGA, SGA, and LGA?
AGA appropriate for gestational age. SGA is small for gestational age.
Okay.
LGA is large.
Okay. When do you say a baby is AGA baby, appropriate for gestational age?
If when we plot a Fenton's chart
Mm-hmm.
based on the hours of life and weight of the baby, if it falls between 10 to 50th%, we'll call it as AGA.
No. Small for gestational age is less than 10th centile.
10.
Okay. Large for gestational age is
More than 90th.
more than 90th centile. Okay. Fine.
So coming to the head to
Can
toe
you
exam.
classify based on the gestational age?
If it is less than 37 weeks, we call it as preterm.
Mm.
If it is 37 to 42 weeks, we'll call it as post-term.
Post-term, okay.
It is less than 28 weeks. 28 to 37 weeks is preterm.
28 to
37.
28 to 37 is preterm. In preterm, there is preterm, very preterm. Let me wait for someone to answer. Okay, how did you calculate weight loss here?
We use a formula birth weight minus today weight divided by birth weight.
Into 100. It's in
Into 100.
percentage,
Yes,
right?
yes.
Okay. So what is the weight loss permitted based on the age of life?
Up to 10%.
Okay. Suppose in a term baby, if the baby is losing, classify it
7 to
based on the age
10%.
of life.
7 to 10% is okay for up to 5 days of life.
Okay. Good. Precisely. Day 2, 12% is permissible. Okay. Day 3, 11%. Day 4, 8%. And then day 5, it is 7%. Okay. Can anyone answer classification of a neonate based on the gestational age? Okay, let us move on. I'll just look into the chat box later.
So coming to the head to toe examination, head is normal in shape and size. Anterior fontanella is flat, patent, is normal in size, that is 2.5 centimeters into 2.5 centimeters. It is measured diagonally and it is rhomboid in shape. There is no caput succedaneum or cephalohematoma noted. Eyes were normal, no subconjunctival hemorrhages or no cataracts. Ears are normal. There are no
Why
lower.
subconjunctival hemorrhages and no cataracts? Why did you ask for that?
If there is any instrumental delivery, there will, due to trauma, subconjunctival hemorrhages happen. And if any metabolic conditions like galactosemia, that leads to cataract in the baby, I should look for.
Very good. Any other birth injury?
No birth injuries.
I mean, any other birth injuries you look for? You have just mentioned it.
We look for cephalohematoma.
Yes, okay, good. Next.
Continue.
Yeah.
Nose is normal. There is no cleft lip or cleft palate. No polydactyly or syndactyly noted. No midline neck swellings or no dysmorphic morphic features. Chest is cylindrical. No accessory nipples or wide nipples. Umbilical cord is having 2 arteries and 1 vein, and umbilicus is healthy. Bilateral hips are stable. So bilateral femoral pulses are present. Spine is normal. External genitalia is normal. Labia majora is covering labia minora completely. Puckering of anal openings are seen. Limbs are normal. Mongolian spots were present on bilateral buttocks.
Okay.
Gestational age assessment was done by.
You said something about bind score there. I think it should...
I should be placed somewhere else.
Okay, fine. Okay.
So gestational age assessment was done by New Ballard score. It contains 2 components. First one is physical maturity. The skin is given 1 point. The lanugo is 2 points. Plantar surfaces are given 3 points. Breast is given 3 points. Eyes and ear are 2 points. Genitals are 3 points. So the neuromuscular maturity posture was given 4 points. Square window was given 3 points. Arm recoil 4 points. Popliteal angle is 2 points. Scarf sign is given 2 points. Heel to ear was 3 points. So the total points, including both the components, is 32 points. That falls between the gestational age between 36 to 38 weeks.
Okay. So you did Ballard scoring, right?
Yes.
And the gestation age of the baby is appropriate, 36 plus 4, and the gestation age with Ballard score is 36 to 38 weeks. Good. Now, tell me, what is the maximum and the minimum Ballard score you get, and to which corresponding gestational age is it?
So the minimum points is -10 and maximum are 50 points.
Okay.
Coming to the gestational weeks, minimum gives 20 weeks and the maximum is 44 weeks.
Okay, good. Now tell me, what components have 5 characteristics?
Popliteal angle.
One in neuromuscular maturity is popliteal angle. Another from the physical maturity?
Skin one.
Very good. Then what characteristics have -1?
Skin.
-1.
Posture.
Yes, posture and both from the neuromuscular maturity. No, it's arm recoil. Fine. Next slide.
Coming to the systemic examination, per abdomen examination was done on inspection. Abdomen was normal in shape, that is round and symmetrical. There are no visible veins or pulsations or distension. On palpation, abdomen is soft and non-tender. There are no swellings or organomegaly. On auscultation, bowel sounds were heard. So respiratory system examination, the barrel-shaped chest and thoraco-abdominal respiration were noted. Bilateral normal vesicular breath sounds and lungs are clear. There are no added sounds or retractions or increased work of breathing. So coming to the cardiovascular system examination, S1 and S2 were heard, no murmurs, and pulses were 12, 3 and 2. So the capillary refilling time was less than 2 seconds. Coming to the central nervous system, anterior fontanella was patent and flat. Child is active, alert, moving all 4 limbs spontaneously. Response to stimuli is present. And coming to the modified bind score, that is bilirubin induced neurological dysfunction score, it is given 1 point. The components are mental status is given 1 point, muscle tone is given 0 points, and the cry pattern is given 0 point, and the fourth component, that is eye signs, is given 0 points.
So what is the difference between bind score and modified bind score? And how do you interpret
Ma'am, in
to
modified,
mild, moderate, and severe encephalopathy?
ma'am, in bind score, there is no eye sign. Modified bind score, eye sign is included. It is given 0, 1, 2, 3 points, that eye signs. 0 point is eyes are normal and the baby tracks the or opens eyes appropriately. And coming to the mild abnormality of the eyes, there is a slow sunsetting sign, that is downward gaze. In second, it is given 2 scores if the sunsetting sign is persistent, and also any abnormal gaze. And it is given 3 scores if the gaze is fixed or there are any absent eye movements. Based on the scoring, the baby was having 0 score.
Okay. So
Coming to the total points, if the total 4 component points are 1 to 3, we need not worry much. If the points are 4 to 6, we should likely to be reversible. And if the points are 7 to 9, that is advanced acute bilirubin encephalopathy, and we should intervene urgently to prevent further brain damage.
your total score interpretation was bind score.
Yes.
Can you tell me about modified bind score interpretation? Mild is 1 to 2, moderate is 3 to 6, and severe is 7 to 12.
Okay.
And in eye signs, both sunsetting sign and the paralysis of the upward gaze both carry 3 marks. 3 points, sorry. Okay. Mild or no eye signs, 0.
Okay.
The other 3, mental status, muzzle tone, cry pattern, all have 0, 1, 2, 3.
1.
Okay. Only eye signs have 0, 3, 3. Right? Okay, fine. Next.
So coming to the cranial nerve examination, the first cranial nerve is olfactory. Baby was turning towards the breast.
To the smell of the milk.
Smell of the milk.
Okay.
Second one is optic nerve. There was brief fixation of the eyes towards the light. Light reflex was present and the red reflex is present. So the coming to 3, 4, and 6th nerves, doll's eye movement is present.
Yes.
Coming to the 5th now, rooting reflex was present. The cheek is palpate, rubbed. The baby was turning towards the cheek.
Fine,
Towards the finger. 7th cranial nerve. On crying, there was no deviation of the mouth or no facial asymmetry. Coming to the 8th now, startle response was noted. 9th, 10th now, sucking and swallowing coordination is there, and there is a good cry. 11th now, contraction of the muzzle, that is sternocleidomastoid muscle was contracted while rotating the head towards side. And coming to the 12th now, movement of the tongue during sucking was present.
Okay, next.
So the coming to the motor examination, posture is flexed. Tone to appendicular tone was upper limb scarf sign was present. Lower limb foot dorsiflexion present. Heel to ear was normal. Axial tone was pulled when it is pulled to sit. The neck muscles are active and head lag is present. So
what is axial tone and appendicular tone?
Appendicular tone is trunk. Sorry, limbs. Upper limb and lower limb. Axial is the trunk. Okay. Coming to the power, moving all limbs against gravity. Musculoskeletal system, no spine deformities or no congenital diaphragmatic hernia or CTEV. And reflexes are rooting, sucking, and grasping reflexes are present. So
what about other neonatal reflexes? What are primitive neonatal reflexes?
Rooting, suckling, grasping, standing, ATNR.
Standing? Placing.
Plantar grasp, stepping, Moro's reflex, Gallant's reflex, glabellar tap. These are some.
When does, okay, you have talked about rooting, sucking, and grasping, right? So when does rooting and sucking appear?
At 28 weeks.
Okay. When do they disappear?
Disappear, rooting disappears by 4 months and sucking disappears by 7 months.
Mhm. Okay. How do you do, okay, when does palmar grasp mature?
At 6th month.
9 months.
Um,
Okay. When does swallowing appear?
Huh?
Swallowing appears at? Swallowing reflex. When does the baby start swallowing?
1 month.
Starts swallowing?
At birth, immediately.
Even in the womb, the baby swallows amniotic fluid, right? So it starts at 16 weeks of gestation. Sometimes when you go for TIFA, you can find the baby sucking and swallowing. Okay,
Okay.
fine. What is the clinical importance of these neonatal primitive reflexes?
Ma'am, if there is high levels of bilirubin, that unborn bilirubin or unconjugated bilirubin crosses the blood-brain barrier and deposits.
It is not related to bilirubin or anything. I'm just asking you a relevant. What is the clinical relevance of neonatal reflexes?
Based on the gestational age, some reflexes appear. This preterm, if it is less than 28 weeks, a routine sucking reflex won't develop.
Persistence of primitive reflexes is a sign of non-myelination, and it can point towards cerebral palsy. Okay. Now, how do you do Morose reflex?
First, we'll catch the baby, and after some time, we'll suddenly release our hands. First, baby will abduct, and then baby's limbs are adducted, and it is followed by a cry of the baby.
Okay. So what are the components of Morose reflex? Come again.
Abduction,
Okay.
followed by adduction, and then cry.
Abduction, extension of
Extension of
elbows, fanning of fingers, then
adduction.
adduction, and then a cry
Cry.
to the stimulus. Okay. When does it disappear? Usually, primitive reflexes disappear at 6 months of age. Persistence beyond 6 months of age is a sign of CPF, as I've told you. Okay.
Yes, yes.
Okay.
Non-myelination.
Next.
Summary.
Okay, there it's summary already.
Baby of Hasina, 48 hours of life, old female baby of 36 plus 4 weeks of gestation, late preterm, with birth weight of 2.6 kgs, appropriate for gestational age, and today weight 2.470 kgs, with exaggerated physiological jaundice, secondary to inadequate perception of milk production in mother, and decreased frequency of baby feeding, with no signs of acute brain encephalopathy.
Okay, here you don't have to mention today weight. You should just write with a weight loss of. Okay. And don't use the word exaggerated. It is just physiological jaundice. Okay. And you don't have to write all this. Secondary to probably, you should be writing it as probably secondary to inadequate feeding. Because you have ruled out sepsis and other conditions, probably secondary to inadequate feeding. That's it. Because this is your summary after your examination, right? And don't use the word exaggerated physiological jaundice, okay?
Okay.
And you can write your bind score here.
Okay.
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 So, let us get into discussion. Can you tell me what is jaundice and what are the sites for your examination of jaundice in
Jaundice
a
is,
newborn?
jaundice is the dermal discoloration, yellowish discoloration of the sclera or the skin. Uh, Generally, visual assessment is done initially
Using Kramer scale.
using Kramer scale. If the limits are over the normal range, then we'll do TCB, transcutaneous bilirubin with
Don't go into investigations. Let us just discuss more things. Okay. So how is the progression? You should firstly, when you're examining a baby, you should examine in a broad daylight.
broad daylight.
Okay. And how you should examine? You should blanch the skin
Blanch.
and look for the grading of yellowish staining of the skin. Okay. Now, how is the progression of jaundice?
From cranial to caudal.
Cephalocaudal, right? Why? By cephalocaudal, do you mean that your face, the baby's face is stained first, followed by the legs?
No.
Then what is the mechanism? What is behind it? What is the rationale behind it?
Takes time to get into extremities.
Pardon?
May take some time to get to the extremities.
No, bilirubin, believe me, bilirubin circulates uniformly, right? What we call cephalocaudal progression is just the gradient of visibility. Okay, the skin at the face is thinner. Okay, and there is rich capillary network. So there is more staining. More staining is visible clearly earlier. Okay, coming to your lower body, your lower limbs have thick skin, right? And there is more subcutaneous fat. So the staining, yellow staining is not visible earlier. Okay.
Okay.
Did you understand?
Yes, ma'am.
Okay, fine. So it is not, so remember, bilirubin circulates uniformly. Okay, fine. Then, okay. So first of all, what is the incidence of jaundice?
Almost in all the babies.
Okay, let us say it is 2/3 of the babies in India. Okay. What is the incidence in term babies and preterm babies?
Preterm babies are more prone to this.
What is the percentage?
Sorry.
Okay. Term babies, it is 60%. Preterm babies, a little more, 80%. Okay. When is jaundice evident or visible in neonates and children? At what level of TSB jaundice is visible in neonates and in children?
In neonates, it is more than 6 mg per DL.
Okay, it is 5. Okay, more than 5. Okay. In older children?
More than 15.
More than 15 now. You have cases of viral hepatitis coming to you. What is the bilirubin TSB value? Even at 2 to 3. Okay, it is visible. Okay. So how is bilirubin formed in the body?
Because of the hemoglobin breakdown.
Okay.
That heme
How
is
much of hemoglobin can form? That much of 1 gram of hemoglobin.
1 gram of hemoglobin forms 35 mg of bilirubin.
Okay. What is the total production in a day in neonates? Total production of first tell me what is the total blood volume in a neonate?
75 ml per kg.
Okay, it is 80 ml per kg. Okay. So what is the, now tell me the rate of production of bilirubin in a neonate. Okay, it is 6 to 10 mg per kg per day. Okay. So how is bilirubin transported in the body?
First, after the breakdown, that unconjugated bilirubin travels to hepatocyte through some carriers, that is ligandin. And then in the hepatocytes, because of the enzyme UDP-GT,
It is bound to what?
bound to albumin, because albumin is a carrier.
So 1 gram of albumin can bind to
8 mg of bilirubin.
8.5 mg of bilirubin.
Okay.
Okay. Now tell me, heme sources and non-heme sources, what constitutes what percentage for bilirubin production?
80% is by heme source.
Okay.
Remaining 20%.
80% is because of hemolysis. Okay. 10% is because of other heme proteins, myoglobins and other heme proteins. And another 10% is because of ineffective erythropoiesis.
Okay.
Okay. Fine. Now tell me, what are the causes of physiological jaundice? In your case, it is physiological jaundice, right?
Inadequate breastfeeding or poor latching by the baby. Decreased frequency of breastfeeding.
Can you give me more precise etiological classification based on age of life?
In preterm babies, there is a poor suck.
No, I'm not talking about term or preterm. In general, depending upon the age of life of the baby, what are the etiological factors and what? Okay, let me say within 1 day, 2 to 3 days, more than 3 days. That is important, right? Within 1 day, it is pathological. Pathological can be due
to any obstructions the liver.
First common thing is incompatibility. Okay. Then
cholestasis.
Cholestasis, no. Cholestasis is a cause for prolonged jaundice.
Sepsis.
Yes, sepsis, very good. And other, we have discussed earlier in your family history.
B6PD deficiencies. Metabolic conditions.
Okay.
Hereditary spherocytosis.
Yes. Intrauterine infections. What is the rationale behind physiological jaundice? Why physiological jaundice? Someone has said polycythemia. Good. It is physiological polycythemia. And there is short lifespan of RBC.
Short lifespan of RBC, and there is also increased RBC mass, increased hematocrit in the baby.
Okay, that is physiological polycythemia. Then I have mentioned before ineffective erythropoiesis. Then immature liver enzymes leading to decreased conjugation of bilirubin. Yes. And then enterohepatic circulation. Enhanced enterohepatic circulation. Okay. What is the normal lifespan of an RBC?
In babies, it is 90 days. In adults, 120 days.
Okay, good. What percentage of etiological factors constitute pathological conditions?
No idea.
5%. Just 5%. Okay. What is neonatal cholestasis? You've been saying cholestasis. So what is neonatal cholestasis?
There is any biliary atresia.
Define neonatal cholestasis.
That is, bile is not going into the intestine from the.
Okay, there's a literal textbook definition. Okay, when the total TSB is less than 5 mg per deciliter, the direct bilirubin should be more than 1 mg per deciliter. Did you understand? If TSB is less than 5, your direct bilirubin should be more than 1. Or if the TSB is more than 5, your direct bilirubin should constitute more than 20%. What are the causes? Causes of what? Oh, okay, let us finish this. What are the causes of neonatal cholestasis?
Choledochal system.
Very good. So there are obstructive causes, hepatocellular causes, and extrahepatic causes completely. Okay. In obstructive causes, two things we commonly come across. One is biliary atresia, and the other is choledochal cyst. Coming to hepatocellular causes, two common things: infections and metabolic. Infections can be torch infections. Okay, very good. Metabolic can be galactosemia, tyrosinemia, neonatal hemochromatosis. Okay, and certain extrahepatic conditions include, again, sepsis, and then some TPN related. TPN is total parenteral nutrition. Okay, fine. What is prolonged jaundice, Sarath?
Bilirubin is there in the intestine for longer time.
Prolonged jaundice is jaundice persisting for more than 14 days.
Okay.
Okay, what is the commonest cause?
Breastfeeding
jaundice.
Breastfeeding.
Okay, and another we have discussed earlier, hypothyroidism, and another is birth injury, Kefil hematoma. Okay. Why is RH incompatibility? I told you before, right? During discussion of incompatibilities, RH incompatibility is more severe compared to ABO, right? Why?
Because there is increased destruction of RBCs, RH incompatibility.
No, in RH incompatibility, the antibodies formed are IgG, right? Because the baby is in utero for so long, and these IgG can easily cross the placenta, okay, and then can ignite jaundice in the baby, okay. Whereas ABO, the IgM and IgG are less potent, okay. The IgM antibodies, they do not cross the placenta, okay. So they cause a milder disease. What happens if both ABO and RH incompatibility are present in a baby?
There will be increased harm to the baby. Increased bilirubin deposition in the basal ganglia.
No, that's actually a misnomer. Okay, ABO is actually protective towards your RH incompatibility. So what happens is these fetal RBCs enter the maternal circulation, right? Then the antibodies against the ABO blood group, they destroy the fetal RBCs, right? When the fetal RBCs are destroyed, there is no exposure of RH antigen. And so the mother is not sensitized to the RH antigen, and IgG antibodies are not formed. And thereby the disease is less severe. So always remember, ABO incompatibility is protective, is a natural protective factor against the RH incompatibility. Did you understand what happens exactly?
Yes, ma'am.
Fine, okay. Now tell me some genetic syndromes causing jaundice.
Down syndrome.
Okay. Other than that, someone has said Rotor syndrome. So what is Rotor syndrome? Yes. Crigler-Najjar.
Alagille syndrome.
Yes. Alagille syndrome. Okay. Wait. First, let us classify it as unconjugated and conjugated.
Conjugated.
Okay. Unconjugated hyperbilirubinemia is seen in Crigler-Najjar and Gilbert's.
Gilbert.
Okay. What happens here? UGT is abnormal.
Abnormal.
Okay. Either it is deficient, it is completely deficient in Crigler-Najjar type 1. Okay. So it is very severe disease and can be fatal. Crigler-Najjar type 1, there is complete deficiency of transferase. Okay. And it can lead to a severe disease and it can be fatal. The Crigler-Najjar type 2, there is only partial deficiency. So the disease is milder. Okay. Then another one is Gilbert. Okay. Gilbert syndrome, here the activity is decreased. So the usual presentation is in the later childhood. Okay. So this is unconjugated hyperbilirubinemia. What are the genetic syndromes that cause conjugated hyperbilirubinemia?
Dubin-Johnson.
They have already said Rotor, Dubin-Johnson. So where is the defect here? The defect is in excretion.
Excretion of bed excretion.
Yes, very good. Okay, so you have said something, Alagille syndrome. What is it?
Impaired excretion.
Hmm?
Impaired excretion.
What are the features of Alagille syndrome?
Metabolic systemic effects.
Multi-system involvement. So what happens? What are the clinical what are the dysmorphic features you can see? Okay, it is triangular faces, broad forehead, deep set eyes. Another characteristic feature, hallmark feature, is butterfly-shaped vertebrae. And involvement of the heart. There can be TOF or pulmonary.
VSD, ASD.
No, not ASD. It is TOF, and if I'm not wrong, it is pulmonary aortic stenosis, commonly seen in Alagille syndrome. So now tell me, how do you investigate? Thank you, Harika.
We'll do TCB, ma'am.
What is TCB?
Transcutaneous bilirubin is checked by an equipment.
Okay, when do you actually rely on TCB?
By Kramer scale, if it is more than the normal ranges.
No, wait. TCB, you cannot do it in less than 35 weeks and less than 24 hours. Okay. only in babies more than 35 weeks of gestational age after first day of life, that is 24 hours of life, you can rely on a TCB
TCB.
reading. Okay.
Right.
Okay. So another next.
Next we'll look TSB,
Okay. What is it?
total serum bilirubin.
Mhm.
Total serum bilirubin.
Right. Okay. Other investigations?
That's it.
If there is incompatibility, what test do you do? Coombs test?
Coombs test.
Okay. Anything else? For if you have attended, okay.
Peripheral
For
smear.
okay. Why peripheral smear?
If there are any hemolysis or to know reticulocyte count.
Very good. Reticulocyte count is another investigation. It is usually elevated in cases of hemolysis.
Hemolysis.
Peripheral smear, same, to look for any evidence of hemolysis. Other tests you do. Think of your differentials.
Metabolic.
Don't go up to
genetic
metabolic.
Disorders. No. Genetic
Don't
testing.
go up to metabolic and genetic first. What was your suspicion? What are the risk factors? Sepsis, hypothyroidism. These are quite affordable tests, right? First, we rule them out. Okay. And then you go for your G6PD deficiency, newborn screening, genetic diseases, all that. Okay.
Yes.
So, okay. How do you differentiate physiological and pathological jaundice based on the presentation?
If the bilirubin levels are increasing in frequency more than 5 mg per DL per day,
Okay.
we'll call it as pathological.
Mhm. And the baby is usually sick looking or anemic. Okay. Then the presentation is within 1 day of life.
1 day.
Okay. Then anything else? We missed this during investigations. How do you rule out obstructive causes?
Ma'am, by clay colored stools, there are.
On investigation. Upon investigation, how do you rule out obstructive causes?
Direct bilirubin is more than 1 mg at any time.
Okay. Ultrasound for biliary atresia. Okay.
Yes.
For choledochal cyst. A fasting ultrasound especially. Okay. Okay. So, fine, you start phototherapy, right? What is the
Yes.
treatment choice in your baby?
Phototherapy.
Okay. So, how do you provide phototherapy?
First, wavelength. All about the wavelength. So phototherapy, the baby is most of the body surface area of the baby is exposed, except the eye patch is kept to not cause harm to the eyes. And then we should, for every 2 to 3 hours, we should rotate the baby. I mean, we should change the position of the baby for most exposure.
Okay, we don't usually rotate positions of the baby. So we have AAP charts, okay, for age-specific cutoffs when you have to start phototherapy or if you have to start your exchange transfusion, you have age-specific nomograms, which we usually follow as AAP chart.
AAP charts.
Okay, American Academy of Pediatrics. Depending upon that, you start phototherapy.
Yes.
So, what is the wavelength of the light, phototherapeutic lights?
460 to 490 nanometers.
Okay. What is minimal spectral irradiance?
Less than 30.
No, what is it?
The current watts.
Minimal spectral irradiance is usually the spectrum of the light and the area it is covering. Okay. In normal there is something called normal phototherapy and intense phototherapy. Okay.
Okay.
If the age-specific cutoffs are nearer to exchange transfusion levels, we provide intense phototherapy. Okay. If the level TSB values are within phototherapeutic ranges, we give normal phototherapy. Okay. The minimal spectral irradiance is usually 15 in normal phototherapy. 15 microwatts per centimeter square per nanometer. It is 30 in intense phototherapy where you put 3 lights.
Yes.
Okay. So normal devices used are LED bulbs, fiber optic lights, and then compact fluorescent lamps. Okay. So what is the phototherapy? If it is effective, it should reduce bilirubin by at least 1 to 2 mg per deciliter per an hour. Okay. If it is not effective and if we cannot reduce it from the level of exchange transfusion, then we should go for exchange transfusion. Okay. So what is the, physiology behind phototherapy?
Configurational isomerism and also structural isomerism.
Okay.
Configurational isomerism, that is 4Z15Z is converted to 4Z15E.
Mm-hmm.
And
Okay, I
structural
think you must have read this. Okay, let us jump to side effects of phototherapy.
First is the dehydration.
Okay.
There is increased oxidation stress to the baby.
So what happens if there is increased oxidative stress?
Oxidative stress leads to the hemolysis of the RS.
Okay.
More hemolysis, more bilirubin production.
What is rebound icterus?
Rebound. That is after stopping the phototherapy. Again, babies will have increased.
Yes. Usually after 12 to 24 hours of stopping phototherapy, we usually counsel parents and family members to look for icterus because there can be rebound jaundice. Okay. What are the other complications?
Bronze baby syndrome.
What is bronze baby syndrome?
Due to this, the photoisomers are not excreted.
What is the component causing bronze color of the baby?
Photoisomers.
Bilifuscin.
Bilifuscin. Okay.
Bilifuscin.
Um,
So why do you cover the eyes and the genital area?
Actually, genital area, there is not much validated information that causes
But still,
harm. But
it is
still we
said
cover.
that phototherapy can cause gonadal toxicity.
Okay.
Then your eyes, the baby's eyes,
Baby's eyes are protected with.
it can cause photoretinitis. Okay. So what are the indications of exchange transfusion and how do you perform exchange transfusion?
Exchange transfusion based on the mother's blood group and the infant blood group. We'll select the donor blood to transfuse. Through umbilical vein, using umbilical vein catheter, we'll transfuse.
What are the indications first?
If the phototherapy is not effective, we go to
No, but there are certain cutoffs.
Based on the term of the baby.
No. If cord blood hemoglobin is less than 10 or cord blood bilirubin is more than 5. Okay. The normal technique we follow is once double volume exchange transfusion. So what is the normal volume of the blood in a newborn? 80 to 90.
Per kg.
So we give double the blood, double volume exchange transfusion, right? So we give 160 to 180 ml per kg. We give fresh blood. Universally, O negative blood and AB plasma can be used. We give plasma and
O negative.
O negative RBC. Okay, this is double exchange transfusion. What is kernicterus?
Kernicterus is unconjugated bilirubin deposition in the basal ganglia. There are 4 types: classical, auditory, motor, and suboptimal characters.
What other brain structures are prone for bilirubin deposition?
Hippocampus.
Okay. Auditory nuclei, oculomotor nuclei. Okay. So you should always, when a baby is jaundiced, especially in the exchange transfusion range, you should follow up the baby for any neurodevelopmental abnormalities. Okay. And you should always get a BERA done for hearing.
Okay.
Okay. Fine. Any doubts?
If anyone
Ma'am,
wants to ask any question, please unmute yourself and ask. You can also use the chat box. If you have any doubts, you can ask.
ma'am, how often we go to the other methods after like even exchange transfusion fails?
Okay. It is rarely we go to other methods like IVIG. Most of the times, if it is due to incompatibility, your exchange transfusion works. Okay. If it is because of other causes like metabolic or sepsis, only then you go for IVIG.
IVIG.
Yeah. And phenobarbital,
Phenobarbital.
clofebrate are not being nowadays used. They're usually given prophylactically to prevent kernicterus, but they are not routinely used. And okay, I see something here, asymmetric brachial palsy. Okay. Sharath, what are the causes of asymmetric moros?
Oh, no.
Okay, limb injuries, Erb's palsy. Okay. Okay, I think we missed some question here. Okay. Yes, I think she answered. Roshni answered it right. Preterm less than 37 weeks, late preterm 34 to 36, moderate preterm 32 to 34, very preterm less than 28. Extreme preterm less than 20. Yeah, right. Fine, okay. So any other doubts? Anyone?
Ma'am, in breastfeeding, breast milk jaundice due to breast milk jaundice will happen. No, ma'am. Even though we should continue giving breastfeeding, then how can we manage?
It takes time, but it with the age of life. See, bilirubin cutoffs, I told you, right? Age specific.
Yes, ma'am.
How much amount of your beta glucuronidase? What is the other component in the breast milk?
T alpha 20 beta pregnant DL.
Yeah, okay. 3 alpha, 20 beta pregnant. How much quantity is present in breast milk? Does it alter with age of life? No, right? It is constant. But the amount of jaundice it causes also stays constant. But what happens with age of life? That cutoff is always the same, right?
Same. Yes.
So likewise.
Doesn't affect much. Ma'am,
Anything else?
also, I read if the baby is kept in a radiant warmer, the phototherapy while giving phototherapy that it should fall perpendicularly.
It should
So why
fall
is that?
perpendicularly, and the distance between the light and the baby should be 35, not more than 35 centimeters.
Okay.
Anything else?
Not from my side.
Okay. Phototherapy. Yeah, in porphyrias, you usually have direct bilirubin, direct hyperbilirubinemia, right? If you give phototherapy in such cases, it can lead to the formation of bilifusion pigment, and that causes bronze baby syndrome. Porphyrias have different line of treatment. It is usually symptomatic. They're genetic conditions, and you should always manage the symptoms. What is okay. Give a few conditions where you see delayed closure of AF, your antenal fontanelle, related to the causes of jaundice.
Some conditions, but they are not related. Not the calcium deficiency.
Hypothyroidism.
Hypothyroidism.
Hypo. Anything else?
Thanks for moderating me. Thanks for giving information.
Thank you. Thank you, Pradeep sir, for your approach towards me.
Thank you, ma'am. You have elaborately explained everything in detail, ma'am. I think all our residents from all over India get benefited with this detailed explanation, ma'am. And even I too have learned a few new points from after attending this class, ma'am. Thank you so much for accepting our invitation and accepting our request for moderating the session, ma'am. And Sarath, it is a nice presentation at your level, and you have done good.
Yes.
Thank you so much, ma'am. Akshara, ma'am.
Thank you, sir.
Thank you, ma'am.
Well done, Sharath. You did a really wonderful presentation.
Thank you, ma'am.
And you have answered well. And I didn't know if I